Anxiety disorders. Introduction. In this study session, our concern is to examine biological concepts of disease and with appropriate case illustrations on anxiety disorders. We will also examine different forms of anxiety disorder, such as obsessive-compulsive disorder, generalized anxiety disorder, and neurotic disorder. At the end of this study session, you should be able to distinguish between obsession and compulsion and point out the symptoms of different forms of anxiety disorder. Classifications of anxiety disorder. Anxiety disorder, which was formerly known as neurosis, is derived from two Greek words meaning nerve disorders, and it was first used by William Cullen in 1769 to designate a general class of diseases due to disordered notions or sensations of the nervous system. Neurosis is a relatively mild disturbance of the mental state that is primarily characterized by excessive anxiety without a demonstrable organic basis. This recent documentation, according to the Diagnostic and Statistical Manual (DSMV-4) classification, has made the use of neurosis as a broad classification obsolete. All other neurotic subclassifications are known as disorders. Common reported symptoms of neurosis include agitation, excessive sweating, hyperventilation, dilation of the pupils, hopelessness, helplessness, insomnia, loss of appetite, loss of libido, derealization, and depersonalization. Part of these characteristics could form a cluster of symptoms of specific neurotic conditions. Neuroses are basically psychogenic, that is, it is largely determined more by happenings in a person's environment and past experience by genetic, constitutional, or physical factors. It could be a learned response to certain traumatic situations. Human beings generally experience certain degrees of anxieties from daily hassles of life. The difference between a normal person and a neurotic person is in the degree of anxiety experienced. Forms of anxiety disorders. Phobic anxiety. Anxiety may be experienced in relation to specific situations or certain objects. When accompanied by a wish to avoid the feared situation or objects, or when the situation is actually avoided, it is known as phobic anxiety state. This state is commonly divided into three groups, namely simple phobias, social phobias, and agoraphobia. The individual with a phobia feels quite helpless, as does the young child, and feels comfortable only when he can make changes to his life so that he avoids the particular phobic situation. Commonest fears seen in phobic neurotics are fear of open places, agoraphobia, fear of height, acrophobia, and fear of enclosed places. An example of phobia developing in a grown woman is summarized below. Folu, a recently married 28-year-old university graduate, has been experiencing some strange happenings for approximately a year. These strange features are characterized by heart pounding without warning, and her breathing becomes difficult. Her hands sweated profusely, her stomach muscles tightened. She frequently experienced these sensations and, at times, she could not stop herself from wondering if she was about to die. Somewhere at the back of her mind, Folu knew that when she closed her eyes and rested, she would feel normal again within an hour. Folu's first experience of this attack occurred when she was leaving a crowded football stadium. The only previous event that could be connected with these feelings was a fearful reaction to a TV story about a nightclub fire which trapped and killed 30 people. Folu's second experience of this phenomenon took place during an argument with her husband about whether to wear a particular dress to a family party. Folu did not remember the details surrounding the third attack or all others she had experienced since. The features are coming almost every day now, whenever anyone disagrees with her and whenever she encounters strangers. Lately, Folu has been avoiding the area where these happenings most frequently occur, and subsequently, she has been spending a great deal of time in the house. Two prominent features are basic to phobia in the above case study. Firstly, there were features suggestive of anxiety, which included sweating profusely, tightening of stomach muscles, and difficulty in breathing. Secondly, there was a tendency for Folu to avoid feared situations. These are the hallmarks of a phobic disorder. There is no single satisfactory explanation for the occurrence of a phobic anxiety state. Nevertheless, separation anxiety has been found to be an important pathogenesis of phobia, and this is especially so in the development of school phobia. Separation anxiety is the fear experienced by a child from a significant other, usually the mother, when attachment bond has been established. It is often referred to as an unresolved overdependency conflict between the mother and the child. Dollar and Miller in 1980 described phobia as learned responses to painful experience which are commonly experienced in children. For example, according to the psychodynamic model, the little boy's castration fear may be found as a responding factor in fantasy of previous injury to the genitals. It could also be a symbolic threat of sexual attack in girls and in boys with passive homosexual tendencies. Behavioral theory of phobia suggests that classical conditioning occurs in the formation of a phobic anxiety. For example, as was explained in the case study earlier, Folu's fear of crowd could be easily described as a fearful reaction to a television story about a nightclub that was set on fire where several people were killed. Obsessive-compulsive disorders. The term obsessive-compulsive disorder or obsessional neurosis is yet another type of anxiety disorder. It encompasses a number of conditions characterized by the presence of obsessions or compulsions. Obsessions are defined as recurrent persistent thoughts, ideas, images, or impulses which are perceived as inappropriate or silly by the individual. Compulsions are motor acts which are resisted but carried out despite being regarded as senseless. They are accompanied by a subjective sense of compulsion and resistance that may lead to increasing tension, which can only be relieved by carrying out the motor act. Compulsions are often associated with obsessions and may occur alone. Obsessions and compulsions are generally found in individuals with well-defined personality characteristics, including stubbornness, rigidity, orderliness, and excessive attention to details. Obsessions are often concerned with avoiding death or germs, preoccupation with sexual or hostile thoughts, which are at complete variance with the individual's very proper personality and excessive concern with one's appearance. A typical example of an obsessive individual was encountered by the author when interviewing in the case of a young man when reading the Holy Bible substitutes the word Jesus for Satan. Generalized anxiety disorders. These constitute the commonest form of neurosis. The predominant symptom is anxiety, which may be presented either as a more or less continuous feeling of tension often with some somatic response or as periodic attacks in which the person has a desperate feeling of panic. The new classification of anxiety, according to Diagnostic and Statistical Manual DSM-4, is known as generalized anxiety disorder. It has also been referred to as panic attack, panic disorder, or panic state. As an illness, anxiety may have an acute onset and may be severe in intensity, appearing against a relatively normal background, or it may be of a chronic nature, present from adolescence in mild degree and may fluctuate in severity according to the current stress factors. Anxiety states could be diffuse free-floating or could be fixed. When anxiety is diffuse, there are feelings of tension which cannot be attached to any object or situation. When anxiety is fixed, it is attached to a particular object or situation. Common symptoms of anxiety include feeling of inner tension and anxious expectation, and they may appear in bodily or somatic symptoms such as palpitations, pallor, sweating, goose flesh, dry mouth, anorexia, indigestion, diarrhea, wide pupils, and frequency in micturition. These somatic symptoms associated with anxiety are mediated through the autonomic nervous system and may involve all body systems. The anorexia which occurs may give rise to a loss in weight. Patients with anxiety may also manifest some emotional preoccupation, which may lead to difficulty in concentration. They may have difficulty in getting off to sleep, which may be disturbed by anxious dreams or nightmares. They may also express fears of insanity and headache. Overbreathing may occur as an acute state, and this is usually common in young women about the time of their menstrual periods. Neurotic disorders. Traumatic neurotic disorder. This is the term applied to an anxiety neurosis that develops following what the patient sees as a serious threat to life. Such a trauma may arise from a serious accident or from a combat stress. It could also result from minor injuries, particularly if the patient has a predisposition to mental illness. Such patients, apart from having the clinical manifestations of anxiety already described, may frequently experience terrifying dreams in which they may relive the traumatic situation. They may develop conversion symptoms, which are functional symptoms added to any physical disability that may be present. Compensation neurotic disorder. Compensation neurosis is normally induced as a manifestation of hysteria, and it poses problems created by secondary gains, particularly when monetary settlement is protracted. Let us assume that a man has suffered an injury at work, with resultant physical symptoms. He is seen by doctors and lawyers and receives the sympathy of relatives and friends with numerous laboratory tests performed. If this attention satisfies dependency needs, such a person could hardly wish for the situation to alter too abruptly, and in fact, he may engage in the practice of malingering, particularly if he thinks any prolongation of the illness duration will mean a judgment in his favor for greater monetary compensation. In some instances, the injury triggers off conflict or anxiety, and through the unconscious mechanism of conversion, symptoms become separated to the initial physical ones. Neurasthenia. This is a neurotic disorder characterized by fatigue, irritability, headache, depression, insomnia, difficulty in concentration, and lack of capacity for enjoyment, and hedonia. It may follow or accompany an infection or exhaustion or arise from continued emotional stress. Prevalence of the neurasthenia in a study among primary healthcare attendees in Ibadan was 1.1%. Goreje, 1995. Hypochondrias. This is a neurotic disorder in which the conspicuous features are excessive concern with one's health in general or in the functioning of some parts of one's body, or less frequently, one's mind. It is usually associated with anxiety and depression. It may occur as a feature of a diagnosed mental disorder, and in that case should not be classified as that, but in the corresponding major category. The hypochondriac may be seen as relating to the environment in a distorted way, in the sense that he or she fails to make meaningful relationships with others. The hypochondriac feels worthless and rejected and attempts to opt out of interpersonal relationships, becoming more preoccupied with his or her bodily functions. The patient may have insight into the fact that his constant anxiety about physical illness is abnormal or excessive, but he is unable to control it. Hypochondriasis must not be confused with psychosomatic illness, in which an organic illness is caused or influenced by the psychological state of an individual. Odejide, Oyewumi, and Ohairi in 1989 had identified a triad of symptoms to be found in hypochondriasis. This includes disease conviction, illness phobia, and bodily preoccupation. Delusion may be a common feature in hypochondriasis. When this happens, it is known as hypochondriacal delusions. Hypochondria are not a common psychological disorder in Nigeria. Goreje, 1985, found a prevalence of 1.5% among primary healthcare attendees in Ibadan, Nigeria. Hysteria. Hysteria is another form of neurosis disorders that is characterized by excessive emotional outbursts, suggestibility, self-centered and attention-seeking behavior with rapid mood swings. It is commonest in young women during adolescence and early childhood. Hysterical behavior can be categorized into three. 1. Conversion hysteria. 2. Amnesia hysteria. And 3. Dissociative hysteria. Conversion hysteria. This is a group of symptoms that affect the special senses or a part of the body which is controlled by the voluntary nervous system. Body symptoms are often produced by suggestion or autosuggestion. There may be an imitative feature to them as well. Conversion symptoms include aphonia, that is loss of voice, blindness, deafness, or paralysis of one or more extremities or parts thereof. Superficially, conversion symptoms may resemble symptoms of a physical illness, but if the patient is observed and carefully examined, the differentiation will be clear. Amnesia hysteria. This set of symptoms consists of disturbance of memory. This may vary from total amnesia to circumscribed amnesia when only a specific experience or series of experiences are forgotten. The mechanism of repression appears responsible for the forgetting of an event or subject, which may be painful to remember. Dissociative hysteria. Dissociative hysteria is a condition in which a certain part of the individual's personality is split off from the rest. This accounts for rare occurrences of double personality and fugue states, and the much more frequent phenomenon, somnambulism, sleepwalking. Neurotic depression. This is characterized by disproportionate depression, which has usually recognizably ensued on a distressing experience. It does not include, among its features, delusions and hallucinations. There is often preoccupation with the psychic trauma which precedes illness. For example, loss of a cherished person or possession. Anxiety is also frequently present, and mixed states of anxiety and depression are also included here. Depression could also manifest as a psychotic condition. When this happens, it always involves delusions and hallucinations. A comparison between neurotic and psychotic depression is made in the table below. With neurotic depression, environmental changes have little or no effect on depression. However, in psychotic depression, mood may lift in cheerful company. In neurotic depression, sleep disturbance is always severe. Early morning waking characteristics, delayed insomnia. However, in psychotic depression, sleep disturbance may be present. If so, there is difficulty in getting off to sleep, initial insomnia. In neurotic depression, retardation of thought and action is common. However, in psychotic depression, no retardation in psychological sense, but may complain of fatigue. In neurotic depression, speech becomes slow as part of process of retardation. However, in psychotic depression, they are usually talkative, keen to discuss symptoms, and frequently complain a lot. In neurotic depression, physical symptoms are marked. They include anorexia, weight loss, impotence, amenorrhea, and common concentration. However, in psychotic depression, anorexia and weight loss are less marked and may even be absent. Impotence, amenorrhea, and constipation are not associated with psychological symptoms. In neurotic depression, delusions are commonly present, but in psychotic depressions, delusions are never present. In neurotic depression, affected individual tends to blame himself for his state. However, in psychotic depression, affected individual usually blames others or his environment.